I'm Dr. Asim Javed. I'm an interventional cardiologist working at Rawalpindi Institute of Cardiology in Pakistan. This is a series of talks to facilitate learning process for performing mechanical thrombectomies in acute ischemic stroke. Let's now discuss a bailout parallel stent strategy. This is a 58-year-old gentleman with left ICA terminus occlusion. Two Solumbra attempts had already failed. Having ruled out ICAD and considering this to be an embolic thing, now is a good time to do the parallel stent technique, in which, in this case, we wired ACA first and then we took a tip injection in ACA A1 segment to confirm that we are in the right place. Then we wire MCM1, confirm the wire position in MCM1 and place our microcatheter there. So now that both the microcatheters are in place, we deployed the first stent retriever in MCA and then removed its microcatheter. Then we deployed the second microcatheter in ACA and removed its microcatheter as well. So we removed both the microcatheters and now we've got both stent retrievers deployed and we have the bare wires coming out and we are holding both the bare wires. And then the next thing we did was we removed both stent retrievers together and pulled out everything, but unfortunately we still could not establish flow. So what we could have done different was to use double save technique, whereby after deploying both stent retrievers, the two ray bars are removed, the microcatheters, and then the aspiration catheter slides over the wires of the two stent retrievers, and then both stents are pulled out simultaneously while doing suction through the aspiration catheter as well. So that gives you maximum success, and in fact you can even have a balloon tip guide at that point and the balloon is also inflated, so that will increase maximum chances of success and reduce the chances of distal embolization. So this is exactly what is shown in this picture in a systematic way. That first thing you do is you deploy the two microcatheters in the two arteries where you want them. You never deploy one stent first and then try to wire the second artery. Your wire is not going to cross through the stent retriever, and even if it crosses through, the second stent retriever will entangle into the first stent retriever. So you always wire first artery, then you place your microcatheter in that artery, then you remove the same wire, and you do not deploy the stent at this point in time. You take this wire and place it into the second artery, and then you park your microcatheter in the second artery. Once both microcatheters are in place, then you can bring in your stent retriever in any of these microcatheters, deploy the first stent retriever, then deploy the second stent retriever, then remove both the microcatheters, and the bare wires that are coming out of the guide catheter, now you need to take them out of your Y connector simultaneously, and then on top of these two wires you bring in your aspiration catheter, which could be Sophia or React, and then you take it right all the way to the clot, and once it hugs the clot, that's the time you start your aspiration. So now you are doing sort of Solumbra with two stent retrievers and one aspiration catheter. So this is the double save technique, and if you have a balloon tip guide, you also inflate the balloon of the balloon tip guide at this point, and then you pull out everything and you get the maximum chances of success. So this is the parallel stent technique. Why you need to remove the two microcatheters and you can't take aspiration catheter from the beginning? Because the two microcatheters cannot go simultaneously through the aspiration catheter. So we have to most likely deploy both the stent retrievers and microcatheters through the guide catheter and not through the aspiration catheter. So this is a 45-year-old lady with 4 hours history of left-sided hemiplegia. Patient had left ICA critical disease, which was non-culprit but was cross-filling right ACA. Right common carotid artery was totally occluded. So basically this was a case of acute on chronic total occlusion of right common carotid artery. 6 French 90 centimeter guide sheath, 6 French aspiration catheter and ray bar microcatheter was taken. Traxus wire could not cross. Pilot 200 and Gaia CTO wires could not cross the occlusion as well. Hornet 14 wire was able to cross the occlusion with the help of Caravel microcatheter. Check injection through Caravel microcatheter tip was done to confirm true lumen. Sophia plus 6 French failed to cross the proximal occlusion side. So we plan to do POBA in presence of distal protection filter. 7 mm spider FX filter was deployed in right internal carotid artery, and then right ICA ostial ballooning was done with 4.5 by 15 mm NC track balloon. Post ballooning there was no flow in the carotid. 6 French aspiration catheter for aspiration was used for aspiration up to the spider FX. So we thought there was no reflow because of the spider FX blockage. But it could not establish flow. So then Trexus wire was brought back into the internal carotid artery and spider FX was removed. Again, aspiration was done with Sophia Plus, and this time flow was established in ICA, but ICA terminus occlusion was found to be occluded. But 1 minute later, the carotid flow also stopped again. This time we decided to deal with ostial ICA first and deployed carotid wall stent 7 by 30 mm. Then we went on to deal with ICA terminus occlusion and performed Solumbra with Sophia Plus and Solitaire X 4 by 40 mm. But after 3 attempts of Solumbra, ICA terminus still remain occluded. We decided to go with parallel stent technique. Right ACA could not be wired and was cross-filled from left ACA. So we placed both wires in superior and inferior deviance of MCA. 2 Rebar microcatheters were placed in both MCA deviance. 2 stent retriever Solitaire X 4 by 40 mm were deployed in ICA terminus starting from proximal segments of M2 deviance. Both rebars were removed and Sophia Plus was brought in, and then the whole assembly was removed as one unit. Right ICA and MCA were recanalized and right ACA was cross-filled through ACOM. Right ICA stent was also patent, and this is our neurologist examining the patient 2 hours later in the ward.
ये पैर उसे उठाओ सीधा, ठीक हो गया। और जी वो दूसरी साइड है वो बाजू उठाओ जरा, सज्जा बाजू उसे उठाओ, शाबाश बस ठीक। और ये सज्जा पैर उसे उठाओ, वो ग्राइंड बस। और ना जरा दस पे अपना की ना थोड़ा।
This is a case of basilar occlusion. 1 attempt of adapt and 2 attempts of Solumbra failed to recanalize basilar artery. We decided to go with parallel stent technique. You can see wire going into left PCA across the distal basilar occlusion. Rebar was parked in left PCA, and then second wire and microcatheter were taken into the right PCA. Now you can see 2 stent retrievers 4 by 40 mm deployed in both PCAs and Sophia Plus aspiration catheter in place, just hugging the clot. Both stent retrievers and Sophia were removed as one unit, and this is a comparison of pre and post intervention DSA images. This is again pictorial representation of the parallel stent technique, and now this is the patient 48 hours later.
ठीक है, बस अपना दायां बाजू ऊपर उठाएं, बाजू ऊपर उठाएं, बायां बाजू ऊपर उठाएं, ठीक है।